Previously on the Dr. Meade Show.
We have a special edition today on hip surgery. I have an expert panel assembled today to answer a lot of questions individually. Let me just quickly introduce the panel. Dr. Pete Sharkey, Professor of Orthopedic Surgery. Pete's an officer in the American Association of Hip and Knee Surgeons. Leo Scarpino, perhaps the most experienced surgeon on our panel today. Mike Bush and I go back to our trauma days at Lehigh Valley. Mike, too, has done thousands and thousands of joint replacements and trained at Hospital for Joint Disease in New York. Kevin Ambari, stellar surgeon, trained at Harvard, University of Pennsylvania, Charlie Ng's fellowship, and actually has an MBA from Wharton. Let me tell you a little bit about hip replacement surgery. It is probably one of the most successful procedures in all of surgery, not only orthopedics. It decreases your pain, improves your function, improves your quality of life.
The pain and disability associated with hip arthritis is absolutely terrible. It's considered one of the most painful, disabling conditions you can have.
The age itself is not a contraindication to doing a hip replacement. I've done recently some 91 and 92-year-old patients who had hip replacements.
I think the issue with metal on metal, and some of it is actually specific to how you position the implants. We've learned a lot more about how certain ways that you position the cup, for example, lead to more wear on a particular part of the metal on metal articulation.
You're not really losing the prosthesis. We're talking about microscopic amounts. You know, they measure in billionths of particles. So that prosthesis is as strong as it ever was, but it's the effect of these micro particles and the body reacting to them.
Hi folks, I'm Dr. Tom Meade. Welcome to another edition of our show, part 2 of hip surgery. What if it was all a lie? Folks, we did the first show and it was unbelievable. We had a standing room only crowd. There was a lot of controversy. We probably spent the majority of the time on metal hips, which is perhaps why most of the folks were here. When we ended our first show, we did have a few questions, so I do want to end up with one or two questions, and then we'll go into the anterior approach, which is equally as controversial, and some folks had asked for some other general topics, so we're going to try to hit them all in the next half hour. So before we start, let me defer to Dr. Ambari just to give a high-level view of the metal-on-metal hips and hip surgery. You know, we tend to talk about the complications of the hip surgery, but again, as we started the first show, this is one of the most successful procedures in all of surgery. So you got to put that in perspective. Kevin?
Yeah, basically I was just concerned about some of the impressions that were being given by some of the questions from the first show. Bottom line is hip surgery, hip replacement surgery specifically, is still probably one of the best surgeries in all of medicine. And now that we know what we know about it, we are even better able to make sure that the hip that we're putting in is something that's going to last the test of time. Most hips, the vast majority of them now are titanium pieces, which are very benign, with a metal ball and a plastic socket, which is as uncontroversial as it gets. So I want to just give the correct impression here that the thousands and thousands of people who are getting the surgery on a yearly basis are doing just fine. And I don't want some of the complications that we've encountered in the last few years to cast a shadow on that. That's all.
Last question on metal hips over here. So again, the question on metal hips is asymptomatic increase in your metal levels on a blood test. And I think Dr. Sharkey talked about that a little bit before, but Peter?
Well, the number one factor which will affect wear, and that's what we're talking about here, is wear. When the hip starts to wear, you get these levels of chrome and cobalt. If it's a plastic hip, you get wear of polyethylene. Ceramic hip, you get wear of ceramic. So you've had increased wear for whatever reason. The number one predictor of increased wear is activity levels. So I don't know if you know, with the better weather we had, whatever, if you were more active, you went on a trip, long bike rides, whatever, you did something probably more activity than you usually do. But it is important to follow these levels because we do know chrome and cobalt in very, very high levels are not good for you. They can be neurotoxic, and there's case reports of people suffering hearing loss, loss of eyesight, all sorts of really serious things. So if your levels keep going up, you've got to get checked, and if they stayed persistently high, I'd get it switched over to a plastic bearing.
Great. Let's move on to the next controversial topic, and I'm going to ask the gentleman in the back to repeat your question. Great question. Let me summarize what you're asking. I think the advancement of knowledge is based on controversy, and if that's the case, we are advancing a lot of knowledge today because there's a ton of controversy. The hip can be approached from the side, from the front, from the back, and really what we're out there trying to do is lower the complication rate. And again, I don't do hip surgery any longer, but my guess, the premise of this approach, Peter, Leo, Mike, and Kevin, was to decrease one of the most common complications, which is hip dislocation. There is no free lunch. There's a learning curve. Your questions are appropriate. As our population gets heavier, is this a harder procedure with more tissue to get through? What's the learning curve? Let me start with Dr. Scarpino, who locally has embraced this, has done a bunch of them. You have to get a special table, special equipment. You have to be passionate about learning this technique. And Kevin, Leo, your early experience on this, and where do you think it fits in your historic approach to hip surgery?
Well, I trained with an anterior approach. We did a Watson-Jones approach when I was in training. I did that for 4 years in training, did it for 4 years when I was in Connecticut. When I moved to the Valley, we switched to the posterior approach, and I've done that for the past 30 years. Now, historically, what got my attention was one of the local physicians had his total hip done 2 or 3 years ago from the posterior approach. He wasn't back to work for 6 to 8 weeks. He then subsequently had his second total hip done through an anterior approach, and he was back to work in 2 weeks. And that's what got my attention, and that's what got me interested in the anterior approach. So I researched it for about a year. I went down to the DePuy Training Center in Miami, took the course with Dr. Joel Mata, who is the pioneer in anterior hip surgery, and have been doing that for the past year. The anterior approach is a minimally invasive procedure. By minimally invasive, I mean it has to do with what we do under the skin and not necessarily a small skin incision. We don't cut any tendons, muscles, or ligaments on the way into the hip. We have a special table called a HANA table that is designed specifically for the anterior hip approach. It allows us to do the procedure under X-ray control, so we have a live X-ray machine throughout the procedure. I'm able to watch the position of the components as I'm implanting them into the body, and I can get them in optimum position reproducibly just about every case. And that's the most important factor in the longevity of the hip. The second thing is, because we do no release of the posterior soft tissues, the dislocation rate drops way down. The posterior tissues are the tissues in the back of the hip. And so the dislocation rate goes down. There are no dislocation precautions post-op. Patients can ride in a car right away. They can bend over and tie their shoes, and there are no precautions from that standpoint. And dislocation is one of the big complications that we worry about. Another complication of hip surgery is leg length discrepancy. I tell all of my patients, you know, I can make you a basketball player if I want, but I tell them, but we don't want to do that. And by using the live X-ray machine in the OR, we measure the bony landmarks on both hips, and we can predictably measure the leg lengths and eliminate that. It's about 99%. There's nothing that's 100%. I mean, even with the X-ray control, we can still be off a little bit, but I spend as much time determining leg lengths as I do almost doing the entire case. And those are the big things. The best side effect for the patient is that the recovery is much quicker. Patients can go back to work if they have a sedentary job. I've had people go back to work in a couple of weeks. They can go back to heavy laborers. It's going to be a little later than that. Patients do better, they recover quicker, less rehab, less tissue damage. The downside of the anterior approach is more to the surgeon than anything else. This is a technically very demanding procedure. It's much harder than the posterior approach. The table has two boots, which we place the feet in the boots, and it has the difficulty with the anterior approach is exposing the thigh bone. We have a special hook that attaches to the table. It's attached to a hydraulic lift. We place the hook behind the femur. It elevates the femur out of the wound, and we're able to do that. Okay. So from a standpoint of patient care, it minimizes soft tissue damage. It greatly reduces the dislocation rates. The leg length discrepancy problem is still there, but we try to minimize that, and the patients recover quicker.
So Leo, I have a rule in the knee. A new procedure better make me faster or better, or both. If it doesn't make me faster, it better make me a heck of a lot better. So is this procedure for every patient? Is it for every surgeon? We'll answer those questions after this.
Does hip pain affect your daily activities? Stryker's revolutionary new anatomic hip replacement may help.
The issue is quality of life. I think it all boils down to that.
Call 1-888-STRYKER to find out which Stryker anatomic hip option is right for you. Stryker's new anatomic hip is designed to help restore your range of motion so you can get back to what's important to you. For details about Stryker's anatomic hip options, call 1-888-STRYKER or visit aboutstryker.com.
Hi folks, welcome back. We're talking about anterior approach, the controversy. Is it for every patient? Is it for every surgeon? Kevin Ambar, you've also embraced this anterior approach. What's your thought on this procedure? Does it make you faster? Does it make you better? Is it for every patient? Is it for every surgeon?
I actually have liked it quite a bit. The main benefit is for the patient. The surgeon is irrelevant, really, from the patient standpoint. It does take a bit of a learning curve, and I did dedicate many hours to training, traveling to different courses, like Leo said, and observing live surgery, scrubbing in on surgery to feel comfortable doing it. I think the procedure actually is kind of a cool procedure. It's nice to have the X-ray there. You have a lot more confidence about the leg length, exactly like Leo said, and the fact that the hip is going to be there and not going to pop out of socket, which is also very nice. I don't think it's for everybody based on a variety of different things. Some anatomic problems in the bones that pre-exist or hardware that exists from before. Some people who are very large, the belly may get in the way of actually inserting the piece that goes into the thigh bone. But several surgeons have actually embraced that procedure as their go-to procedure for hip replacement. So when you said before about, oh, you know, there are multiple criteria, well, sure, but overall, you can actually do quite a few people from that approach. So it's not for every patient, but it's probably for a lot of patients potentially. But primarily, the surgeon who does it has to be comfortable doing it and has to feel comfortable that they're doing the right thing for the patient. So that depends on a conversation you have with your surgeon.
Mike Bush, you do thousands of joint replacements. Traditionally, you probably had a different approach. What would stimulate you to look at this approach or not?
Well, I still am doing a standard mini posterior approach. And I think you have to look at the history of orthopedics and see everything that's been done, and it's the latest and the greatest, and everybody rushes to it. And then 5, 7 years down the line, they find out there's complications. The best example was maybe 3 to 5 years ago. Zimmer was pushing their mini two-incision approach. There was a tiny little incision in front and a tiny little incision in back, and everybody was rushing to it. And then as it got out into the community, they found out that there were a lot of complications associated with this, a lot more than was seen in the studies that came out and the people that were proposing it. So I've kind of taken a step back and wait until it's out longer and make some decisions as to long-term effects, and then I would consider switching.
They do say in orthopedics not to be the first or the last, or actually probably in all of surgery, not to be the first or the last to try any procedure. So I agree with the sentiment. With the anterior hip approach, it's not something that was just created yesterday, though. This has been something that was studied at length for years, and I think even with the new push in the last few years, it's not something that just came out in the last month or year. I've actually watched it and waited to see if it was going to balloon or whether it was going to go by the wayside, and it looks more the former than the latter. So that's why I decided to go on. What do you think?
At the Rothman Institute, there are 13 joint surgeons, and I'm sure they agree on every single approach to every joint, Pete. So why don't you tell us what all 13 surgeons agree to and which single approach they would all use on every case?
Yeah. Well, believe it or not, the number is now 16. We hired 3 more this week. So, but in truth, it is 16 total joint surgeons. And we use a lot of different approaches. We have doctors who use a posterior approach. We have doctors who do a direct lateral approach. We have doctors who do an anterior approach. So everybody's doing different things. I do an anterior approach, and I also do a direct lateral approach. Most of the approaches I do are anterior, but not all. And I've got to tell you, one of the things that you have to understand, and this goes back to what Tom Meade said a little while ago, hip replacement is, I'm not going to say it's one of the most, it is the most miraculous operation that doctors do today. You can take somebody who's essentially in a wheelchair and restore them to a very high quality of life. And you can do it through any one of the 4 different approaches to the hip in a very predictable, reproducible way. And so the biggest thing is you should go to a surgeon who does a lot of them, who's comfortable with the way he's doing them. He has a lot of experience with it. And honestly, one of the things that drives a lot of this is marketing. Because, for example, let's say one of you goes and sees a doctor who does a posterior approach, mini posterior approach, let's say, and you get an absolutely perfect result. You're going to go tell all your friends, you got to see that doctor. He does this special mini posterior approach. It's great. Or my doctor does an anterior approach, and I am perfect. You got to go see somebody who does an anterior approach. Truthfully, all the approaches work phenomenally well as long as you go to a surgeon, like anybody on this panel, who does a lot of them and has a lot of experience doing them.
Dr. Scarpino, I cut you off there. You had a comment?
I agree 100%. Like I said earlier, I've done the posterior approach for 30 years and had excellent results. It's still the most widely used procedure in the world, and the results are excellent. As I outlined, I felt that the anterior approach had certain advantages over that, and that would help the patients, and so far they've been pretty good. The patients have been very pleased.
Yeah, I would just like to add one thing, that one of the pushes for the anterior approach was the lower dislocation rate. One of the new things that's happened technically in orthopedics is we're using much larger balls, which has essentially eliminated the dislocation rate. So there's less need to do that.
Let's take a question from the right. Great question. Do we have to replace the whole joint? Can we just resurface the worn out articular surface? Anybody on the panel do hip resurfacing? Kevin, you got it.
I think basically the point of resurfacing is that instead of cutting off the ball of the hip or the top of the thigh bone, you're just basically taking the surface off and putting a new surface on it. It certainly makes sense from a common sense standpoint. You're saving bone. I think if you go on the websites, you see a lot of claims to that procedure that aren't justified. You see people climbing rocks, and it makes it sound like it's such a different procedure than hip replacement. Truthfully, a younger, active male patient can probably do the same activities with a hip replacement as they can with a resurfacing. The one thing you're definitely doing differently is that you're saving bone. You're not putting the thigh bone component inside the thigh bone, you're just putting a surface on the top. So that's really the true advantage. At the same time, it's by definition a metal-on-metal hip. And if you heard a lot of the questions about metal-on-metal surfaces and some of the issues with it, that's, I think, why it's become less popular over the last 1 or 2 years, because we're a little bit more apprehensive about the whole metal-on-metal issue. For some people, though, I think it still makes sense if they are a young, active male. When it comes to indications and contraindications, I think that one you really have to have a good conversation to see if it makes sense for you or not. I've had people who are, you know, a 7-year-old female who comes in and asks for a resurfacing. That wouldn't make sense for that person at all. Really makes sense in a certain subset of population, and they have to be fully aware of the whole metal-on-metal issue and whether they're comfortable with that. And some people really are, because they don't want plastic in their hip for whatever reason, and they like the idea of just putting the surface on instead of putting the piece down in the thigh bone. I actually saw a show on TV recently. It was a documentary about foreign tourism, medical tourism, and this guy who didn't have insurance went to India to have a medical resurfacing done, a hip resurfacing done. So I thought it was kind of interesting, but I think it makes sense in a certain subset as long as you're aware of those issues I said.
So folks, there are alternatives to the complete hip replacement. We just heard about hip resurfacing. There are other alternatives. We'll hear about them right after this. Hello folks, I'm Dr. Tom Meade, a native of northeastern Pennsylvania, who began my surgical training here in 1983 and returned to make it my home for almost 30 years. I now limit my practice to knee surgery on patients of all ages from 13 to 99. I am part of Coordinated Health, one of the only private, physician-owned, surgeon-directed hospital networks in the country. We are proud to contribute to the fine reputation the Lehigh Valley enjoys for its advanced healthcare. We have become a destination center for both patients and surgeons seeking us out for our expertise in patient care and surgical techniques. Please join me as I host Real Life in the OR, where you'll see real surgeries on real people and hear their real stories. I also host the Dr. Meade Show, where we have medical experts and a live audience discussing topics to improve your health and quality of life. Please join me. You won't be disappointed. Hi folks, we're back talking about alternatives to hip replacement surgery, and we have a question in the audience. That is a great question. The question, I'll repeat that. If there is a lucency or a space between the hip prosthesis on the x-ray and the bone, what does that mean? Is it cemented or uncemented? Does it hurt or not hurt? Does it need a revision? Great question. I'll ask Dr. Bush.
Well, I think the first issue is, does it hurt? If it doesn't hurt, you may not want to do anything about it. And then you get into some more technical issues that if it's loose, is there a lot of bony reaction around it where the bone has been eaten away and we know it's going to fail sooner or later, and it's better to do it earlier rather than later. So there's a lot of technical parts that go along with it. But for the most part, if it doesn't hurt, you may not want to do anything about it.
Next question. Yes, over there in the blue shirt. Great question. Can you buy a dozen hips when you're 20 at the Econo hip store and then have your surgeon put them in when you need them? That's a great question because you don't know what they're going to cost in the future. So I'm going to ask Dr. Sharkey, is that a good approach?
You know, first of all, you have to understand our technology has evolved light years. It's just unbelievable how much longer hips last today than they did 15 or 20 years ago. Really, two reasons. One is better fixation of the parts to the bone. Instead of using bone cement, Tom mentioned that earlier, that we used to attach the parts with bone cement. Worked great for 10 or 15 years, but then the cement would crack and break oftentimes and have to be redone. The other part is, the other aspect is the moving parts of the hip, the ball and socket. And those are bearing materials. And just like a bearing in your car, those parts can wear out over time. And so we've improved the bearing surfaces tremendously through a lot of different ways. some using alternative bearing surfaces like ceramics and metals. And we found there's problems with those, but probably the biggest breakthrough is a concept called cross-linked polyethylene. And what we found about, late 1990s, early 2000, that if you take the polyethylene, and that's the plastic in the hip joint, and you take that polyethylene, warm it up, and then expose it to radiation, it cross-links the long polymeric molecules and essentially reduces the wear to zero. And I'll give you an example. I had a 50-year-old patient I did 12 years ago. I did his hip when cross-linked polyethylene first came out. Big guy, 6'2", 220 pounds. He's now 62 years old. He has been running 5 miles a day, 5 days a week for 12 years. I saw him in the office this past week. I could not detect 1 millimeter of wear after 12 years of that kind of activity in a big active man. So it may be with cross-linked polyethylene today, even for relatively young active people, we may have a lifetime total hip.
Yes, sir. Dr. Bush, rehab, value of rehab after a total hip, or prehab, before or after?
Well, I always tell my patients that day 0 of your rehab is not day of surgery. It's a year ago when your hip was so sore that you stopped walking on it that those muscles began to weaken and atrophy. So I think rehab is very important in terms of returning full function to the person. The actual technique of hip replacement isn't changed that much. It's not going to make your hip more stable mechanically, but you will walk better if you do the rehab and return those muscles to their normal state.
Great. We're coming to the end of part 2 of hip surgery. What if it was all a lie? We have assembled one of the greatest panels of hip surgeons, not only in the Northeast, in the country. The docs in front of me perform close to 4,000 joint replacement surgeries a year. This is the best response, standing room only. This is a great, great audience, and I get the sense that we have not even touched on some of the questions. I'm going to make an executive decision and say there's going to be a part 3 to this show to address some of those issues, and we're going to do that. We're going to do that today. I'm going to impose on this panel. This is a great panel. It took so much work to get them together. These are busy folks. These are questions that you want to ask. So we're going to stay here another half hour and have part 3 of the show. Thank you for joining us, and join us on part 3.